Here we go. Welcome to Lunchtime Live at the Center, where we talk about important fertility-related topics to inform and support your journey. My name is Ami Choksi. I'm your host, and today we're talking about genetic testing with IVF. Specifically, it's called Preimplantation Genetic Testing, or PGT. And Dr. Claudio Benadiva, who is a lead physician and our medical director, is back with us to discuss this testing option. Welcome back, Dr. Benadiva.
Thank you, Ami.
So first of all, what is PGT?
Well, PGT, as you just said, stands for Preimplantation Genetic Testing, which involves doing genetic testing on the embryos before they are implanted into the uterus. That's why it's called preimplantation. So basically, the embryos are tested in the lab. They are typically frozen because it takes several days to get the results of the testing. And then they are implanted, usually one embryo that's been identified as normal will be implanted in a subsequent frozen embryo cycle.
Okay, so why would someone have this test done?
Well, there are many different reasons why patients have PGT. In fact, the name of the testing has evolved over the years. In the old days, used to be called PGD, and that was just everything was called PGD, and that was preimplantation genetic diagnosis, and that was a mixture of different types of genetic testing for the chromosomes, testing for a specific disease like cystic fibrosis, for example. So over the years, the name of this test has been kind of refined to be more specific. From PGD, then we evolved to what's called PGS, and a lot of patients may still find PGS as the name of the test, so preimplantation genetic screening. And that was used until not too long ago to define when the testing was done for the chromosomes. Every embryo is supposed to should have 46 chromosomes. You get 23 from the egg, from the mother, 23 from the sperm, and they should form an embryo with 46. And a lot of times there are errors in those numbers, and they're either missing a chromosome, and the embryo will probably not even implant, or they can have an extra chromosome. It's called a trisomy, and that is a very common cause of miscarriages. If the extra chromosome is the number 21, that's Down syndrome. That can cause Down syndrome. So those are the kind of chromosomal errors that were tested, can be tested. They used to be called PGS. Well, nowadays, they're all called PGT, preimplantation genetic testing. And depending what we are testing for, then you add another acronym. For example, if we are testing the chromosomes, we are counting how many chromosomes. It's called PGT-A. And A stands for aneuploidy, which is abnormal number of chromosomes. So that's probably the most common testing that we do is the PGT-A, or formerly called PGS. There are couples that are carriers of a genetic disease. For example, both parents carry a gene for cystic fibrosis or sickle cell, or one of the parents carries a gene for, we have patients with all kinds of gene carriers, for example, Huntington's disease or Tay-Sachs. So in that case, we're testing for a specific disease, and that's called PGT-M. And M stands for monogenic disease. And there are other forms of PGT testing. There are some couples that have a lot of miscarriages, and we find that they have it's called a translocation. And that's a rearrangement of the chromosomes. So basically, the chromosomes break apart and they swap parts with each other, and they become rearranged. So that's a PGT-SR, is for structural rearrangements of the chromosome. So depending what the specific problem for the patient or for the couple, we will test the embryos for that specific problem.
And how do you determine who needs this?
Well, there are different ways of determining that, or different indications. The checking of the chromosomes, for example, the PGTA, which is the most common, that can be applied to any patient who is trying to get pregnant, because we're just trying to identify chromosomally normal embryos that will have a higher chance of implanting and making a healthy baby, and provide that patient with a lower risk of miscarriage, and of course a lower risk of Down syndrome. So in general, for patients that are over 35, that becomes a little more helpful, because the risk of having abnormal embryos goes up with age. So that again is available for any patient who's obviously doing IVF. There are patients that we know they need to have the testing because we identify them as carriers of a genetic disease. And that can be done either because it runs in the family, they already know, they have been tested. It could be because they already have a child born with a genetic disease, and that's how they find out. Ideally, what we do now with all our new patients is to offer genetic carrier screening. So patient will have a DNA test to see if they're a carrier of a genetic disease, and potentially test the partner as well, and determine that way if they are carriers, they could benefit from doing the genetic screening of the embryos before they are implanted, because we know they have that particular risk. So again, there are different reasons. There are couples that come to see us because they have many miscarriages.
Okay.
We do a blood test, we check the chromosomes, we find that they have this translocations that I mentioned before in their chromosomes that has been the cause of their miscarriages. So then we will offer them PGT to identify the embryos that don't have it, that they're normal. Again, different reasons, different indications, different types of testing, depending what the couple's situation is.
So this has evolved over time, and it's gotten better and better. What are some of our, what are the chances of conceiving when a patient takes one of these, especially like the PGTA aneuploidy one?
Right. Well, that's especially for women over 35. It's most studies have shown a benefit, because otherwise we will be just picking randomly a nice looking embryo without knowing anything about the chromosomes. And if they are not normal, the embryo will not implant or could potentially miscarry. So we have found in our clinic, and that's consistent with many others, that when we implant an embryo that's been tested, the chances of that embryo implanting, making a healthy baby, are significantly higher than picking one embryo randomly. Another nice feature of doing this PGT testing, especially for older patients, is that when you look at the guidelines, the ASRM guidelines for the number of embryos that you have that is recommended to transfer in older patients, is more than one. Depending on the age, could be two, could be three, especially women over 40. When we do the PGT testing, we only implant one embryo. So that presents a lot of nice advantages, because there is no risk for, virtually no risk for multiple pregnancy. We're only transferring one embryo, one normal embryo has been tested. We don't have to implant two or three or more like we used to, even for the older patients. Now, without the testing, of course, if you want to increase the chances, we follow the guidelines, and we transfer multiple embryos, and that can result in multiple pregnancies. We are trying to avoid that.
Is this test done in the office?
But part is in the office, and the actual genetic or DNA testing is done by an outside lab. So in the office, we make the embryos. We grow them in the incubator until they become a blastocyst, which is a fully developed embryo. Our embryologists are very skilled, and they will do the biopsy, which involves just removing a small number of cells from each blastocyst and freeze them.
Okay.
At that point, we still don't know the results, so they're frozen, waiting for the report. The cell sample, the biopsy, is sent out to a genetic lab. We only work with the most reputable genetic labs that have many years of experience and use the most advanced technologies. In fact, the past year they use now AI, artificial intelligence algorithms to read the results of this DNA testing, and that actually has made the test more accurate and more robust. So that test is done by an outside lab. We get the report after a week or two, and then we plan the frozen embryo transfer once we identify the normal embryos in the report.
And at what stage of an embryo, at what day embryo, does it go to the lab?
Well, so the embryos are in the incubator for anywhere to up to 7 days. That's really the limit.
Okay.
So as soon as they become blastocysts, we biopsy them, and that happens usually between day 5 or 6. Occasionally, even day 7. If it looks like they're developing, we give them the benefit of the doubt. We keep them for 7 days. So anywhere between day 5 and 7 is when the biopsies are done, and the embryos are then frozen after that.
And is there an ideal number that you want to send, a minimum, a maximum?
Well, of course, the more the better, because we don't know what the results are going to show. But we have sent anywhere from 1, the minimum, and there are patients that only get 1 embryo, to, I don't know, 19, I think was the maximum, perhaps.
Yeah. So is there a cost associated? Is there a flat rate? Or is it based on the number of embryos that are
right? So that's a good question. The biopsy is the same cost. Doesn't matter if it's 1 or 10 embryos. For the testing, the genetic labs, they have different fee schedules. For patients that only have a few embryos, they get charged per embryo fee, which becomes a little more cost effective. Otherwise, there is a fixed cost up to 8 embryos, and any additional embryos after 8, they charge per embryo if there is more than 8, which is very rare.
Is the cost out of pocket, or is it sometimes covered by insurance?
Well, that's another good question. It depends on the insurance. It depends on the reason for the PGT. My experience is when patients are carriers of a genetic disease, it's more likely that the insurance will cover the testing. There are patients, for example, that want to do it for gender selection, for family balancing. They want to have a baby of some specific gender. They already have 3 girls and 1 boy, or vice versa. So in those cases, it's very unlikely that the insurance will cover it. So I think it's something that we always look on a case-by-case basis. There are insurance that are better than others, and will cover it.
Now, once someone has this test, who counsels the patient on the results of the test? Do we do it, or does the company that we send it, the lab that we send it to, does it?
That's a good question. No, usually we do it. I call my patients, so every physician will call the patient with the results. The genetic lab, that's a good question. They do have genetic counselors that speak to most of these patients, and they typically speak to the patients before their IVF cycle to prepare for that.
Okay.
and they are available to discuss after. So if, for example, there are some borderline results or some complicated results, like mosaic embryos,
Mm-hmm.
there's a lot of controversy about those. Uh, the genetic counselors are available to speak to the patients, and they have, a lot of good information that they provide to the patients. So I would say both. Primarily, we talk to our patients, and the genetic counselors are available as well.
What happens with um, the embryos that are not normal or mosaic?
Okay, so that's a great question. We have a policy: the embryos that are abnormal, clearly abnormal, we don't transfer those embryos.
Okay.
So we will consult with the patient, with the couple, and potentially discard them if they are not interested in using them. Of course, it's very very rare. We almost never had a patient that wanted to transfer an abnormal embryo, and we will not. Um, Perform that. Mosaic embryos is a different story because those are very close to normal embryos.
Hmm.
The more we learn, the more experience we accumulate. This can produce healthy babies. And I just saw a patient 10 minutes ago. We transferred a mosaic embryo, and she has a healthy pregnancy, and another one had yesterday. So those embryos are, for people listening that don't know what we're talking about, mosaic embryos is when the report shows that there is a mixture of some normal and some abnormal cells. Okay, so in the biopsy, which is a small sample of the embryo, maybe one or two cells were abnormal and the other ones were okay. And with the technology that is used today, this can be detected. And before, of course, we didn't know because the technology didn't even detect that.
Hmm.
So in the beginning, we thought these embryos, were not normal, but actually, the more we learn about it, we know that they are very close to normal. There are a lot of different theories. Maybe they fix themselves or they correct themselves. Maybe the normal cells grow and the abnormals just don't. But we counsel the patients depending on what specific chromosome is involved. There could be more miscarriages with these embryos. The success may be a little lower,
Mm-hmm.
but they definitely can result in healthy babies. So, when do we use mosaic embryos? Obviously, the normal embryos are always the first priority. So, these mosaic embryos are sort of a second choice. And patients that, for example, don't have any normal embryos, they only have a mosaic available, they may not want to do another IVF cycle. They a lot of times they want to try this to transfer the mosaic embryo, and I have seen very very good results, almost very close to the normal embryos. There are patients that don't want to do another cycle, or they have tried and they're all abnormal, and the best embryo they have is mosaic.
Mm-hmm.
So we could use them if the patient agrees. It's really a discussion between the physician and the patient. There are patients that prefer to do another cycle, and some others are more comfortable. This is a good example of a scenario where we will recommend that they speak to the genetic counselors from the PGT, from the genetic lab, because they can provide the patient with even more additional information to, the one we have,
Okay. So it sounds like
and help them make a final decision. But yeah, it's been a controversial area, but and again, it's still progressing because these are all new developments in the genetic testing field.
Has anything developed, or have we learned anything specifically with the PGT AI, where the algorithms do a lot of work?
Right. So yes, the PGT that is offered by some of the labs that we work with, they basically is incorporated artificial intelligence to the reports. So instead of having a person, a technician, or an PhD in working in the lab and looking at the report that comes out of these computers and deciding if this embryo is normal, abnormal, or mosaic, they use machine learning and artificial intelligence algorithms. So they knew the outcomes of thousands of embryos because they have a very large database with a lot of information, and the computers know what the report looked like coming out of the computer of these DNA sequencers, and what the outcome was. So they learn, and they're much more accurate. So we notice, and the company that issues the reports also notice that the results are more robust, they're more accurate. So we start seeing more normal embryos than we used before, and less borderline results like mosaic. So it became more precise by using computers to learn to read these reports.
Is it one or the other, PGTA versus PGTAI, or is it something that they use for both? Is it human and
right? That's more depending on the lab that applies it. One of the companies that we work most frequently is called Cooper Genomics. They use that for all their reports.
Okay.
So we don't have to ask for it; it's automatically used. So there are some other labs that use different platforms or different technology. They may not use that particular AI technology, but I would say most of our patients use it. Will get the benefit because it's done as part of their testing.
Science is amazing. Can these embryos be tested for things like autism?
That's another very common question. Unfortunately, the answer is not yet, because nobody really knows what causes autism. There is no specific single gene that causes autism that we can test for. So you cannot test the embryos for something that has not been really identified yet. What we have done occasionally, couples that or either already had an autistic child or runs in their family, is gender selection. Autism is more frequent in boys than girls. So I have had a couple patients who wanted to select for a girl to reduce. That's not going to eliminate it,
right?
But it's a way of reducing their risk because of that, increased incidence in boys. But other than that, there is no gene for autism that we can test for, at least not yet. I'm sure in the future something will be identified.
Would that be something that an older couple would you mentioned this couple? Is that typically something an older couple would do? Does it matter how the age of the parent?
No, well, it matters in terms of not necessarily autism, but Down syndrome, for example.
Okay.
So absolutely. So for older patients, and for reproductive purposes, older is not that old. Anybody who's over 40 has pretty significant risk of having embryos with that could have Down syndrome or other errors in the chromosomes that will miscarry. The risk of miscarriage is naturally pretty high after the age of 40. When we test the chromosomes, then we're able to reduce that risk because we are identifying all the abnormal embryos that miscarry and don't implant them. So the answer is yes. For older patients or older couples, doing the PGTA to check the chromosomes, it's a nice way to prevent that.
And is there anything? So this is something that I would think about if it were, if I were in this situation. Is there anything someone could do to have a better outcome, a better chance of a normal test, PGT test?
Yeah, that is a frequent question, especially when if we have patients that do the testing and all the embryos are abnormal, for example. What can we do to change that? There are not a lot of things that we can do because we don't really control the genetics of each egg or each sperm, but definitely there are things that we always try. For example, we can give these patients some supplements, some nutritional supplements like CoQ10 or the HEA, some things that are potentially helpful to improve egg quality. We will try our best to get more eggs. We get more eggs, we get more embryos, we got a better chance of finding a good one. The IVF lab, will also use some different methods to select the sperm because it's not always the egg. So there are some different techniques or different devices to select the best quality sperm to fertilize that egg. So we may try that. So usually we will look at all the menu of options and pick the ones that we think can help.
Okay. All right. Well, we're coming towards the end of our hour. I'm looking at the questions, and I don't have any questions, but I do have some nice compliments for you. My favorite Dr. Benadiva. My favorite Dr. Benadiva. So really nice. We're coming on to the holiday season. What is your favorite part of the season?
Oh, my favorite part is getting all the Christmas cards or holiday cards from patients. It's amazing. Even here where I get Christmas cards with teenagers, babies that were born, I don't know, 20 years ago. We still get the cards. So it's really beautiful. I was just showing. I just got a card from a male gay couple that has two girls with our help, and of course, a surrogate, and will help them, have a beautiful family that years ago that probably would have been impossible. And
right.
So that's the best part is we start getting lots and lots of Christmas cards at this time of the year.
Nice. Someone asked, share your favorite item that we can send as a gift to Dr. B.
A good cigar.
Oh, there you go. All right, Dr. Benadiva, thank you. It's always nice talking to you. And thank you for sharing about PGT and all of the acronyms that go with it.
Thank you. My pleasure.
Well, we'll be back next week for another Lunchtime Live. And be sure to check out our website at uconfertility.com for additional information, as well as a calendar of events to support and to help you feel connected. So see you next week.